Thank you, Stefan. You always feel honored when the program planning committee asks you to give a lecture, and then you start thinking, why am I invited the third time for such a session? And maybe the program planning committee knows something about your performance you should better know yourself. Well, but here I am, and I would like actually to present one case which I think really has a teaching value. This is a 42-year-old female she's quite overweight, BMI 52, 165 centimeters, 142 kilos, and she was diagnosed at an outside institution with sigmoid colon cancer with 4 liver metastases. And they thought this could be resectable and started a neoadjuvant chemotherapy, but she developed quite severe side effects, a rash, which made it necessary to stop in between with the chemotherapy, and then for scheduling problems she had to wait for the surgery, because usually you do now a liver first concept, so you do neoadjuvant chemotherapy for the liver metastases and then resect the liver metastases, and the second step, resect the colon cancer. So while waiting for the liver surgery and not getting chemotherapy, obviously the sigmoid cancer started to grow again and progressed, and she got bowel obstruction and needed an acute operation for the colon. And then she recovered from that, but obviously she was not very happy there in the institution, and she came to us seeking for a second opinion. And that's in the situation when they come with a lot of DVDs, you don't get the reports, maybe the summary, and the original report is always with the patient, but the patient is not here, just the DVDs. And we put all the DVDs on the CTs and MRIs, and I'll show to that into our system. So this is the venous phase, single venous phase scan they did there. Obviously because of radiation concerns, you see the DLP of a single venous phase still more than 1,000 milligrays per centimeter. And you see there are 4 lesions here in the liver. 1 and 2 in roughly at the border between segment 6 and 7. And here is another lesion in the left lobe, and the 4th lesion could only actually be seen nicely on the coronal scan. And then they did, it was said, 4 metastases. And then they did, 2 weeks later, actually, they did a triple phasic CT scan, unenhanced. I'm not going to show you these images, but arterial phase and venous phase. In just one image, you see there are these 2 lesions in the right lobe, here one, and the one subcapsular lesion. And the report said bilobar metastasis most likely, and see the DLP 1800, so roughly 35 milligray, so quite a lot because of the obesity. And then they biopsied that lesion here, the large one in the parenchyma, and it turned out to be adenocarcinoma biopsy, fine. Then they did, after chemotherapy, they did a follow-up scan in December 2016, and then what they saw was 3 lesions were completely the same, and 1 lesion, this one here, obviously was shrinking from 18 to 10 millimeters. So the reported shrinkage of lesion in segment 6/7, other lesions stable after chemotherapy. And then 2 weeks later, actually they performed an MRI with gadoxetic acid, and here are the T2 weighted turbospin echo images. You see this is the 1 lesion here in the subcapsular position, and this is again in the adjacent slice, and you see this is the best image actually of this other intraparenchymal lesion on the T2, and this is the 3rd lesion here in the left lobe. And with gadoxetic, after 3 minutes, I don't know whether you can appreciate it, here is that lesion intraparenchymal, and look at this lesion here, and look at this lesion there, and with gadoxetic in the hepatobiliary phase. Of course, all of these lesions were hypointense because they did not take up the contrast in the hepatobiliary phase. And the report said 4 metastases, shrinkage of lesions as segment 6/7. 7. And that was the time when she was then seeking second opinion at our institution, come with this bilobar metastases. And at the MDT meeting at our institution, we said, well, let's plan the resection because we have a quite good experience with the perioperative management of these obese patients, because we have a lot of these obese patients. But still, let's go for another round of neoadjuvant chemotherapy. And after neoadjuvant chemotherapy, another CT was performed. You see this lesion here and this lesion there was actually not changed, and the third lesion here. So metastases unchanged, let's go for surgery. And because of the two lesions in the left lobe, the left sector was resected in kind of an atypical resection here in segments 6 and 7. And after that surgery, we had to wait for a few days, and then the histopathologic report said severe steatosis, 3 hemangiomas, no metastatic deposit. And if you look here, this is from the surgical specimen. Clearly it looks like a hemangioma. You see these blood-filled spaces, and upon magnification, obviously there's no metastasis. And with this report in hands, obviously an alarm bell went off. And you could really see that the surgeons got hectic, immediately called the pathologist. And of course, we had to do a second review of these outside gadolinium or actually Primovist enhanced MRI. And when you go back and look carefully at the MRI, actually there is a difference in signal intensity between these lesions here marked by the yellow arrow, which are quite bright on T2, and this lesion there, which is only minimally hyperintense on T2. And if you look at the dynamic phase image here, actually you see that there's a small peripheral nodule of enhancement in this lesion here and in this lesion there, which you don't see in this lesion. So eventually it turned out, and the pathologist called, there is one metastasis he found in this surgical specimen of the atypical resection in segments 6 and 7, which was actually 1.5 centimeters in size. And you see here that's a metastasis. But the other 3 lesions were hemangiomas, the ones that actually did not change during chemotherapy. So the take-home messages, at least for me in this case, are really review all the images from the previous examinations at outside institutions, and actually that response of only 1 liver metastasis, this can happen upon chemotherapy, but certainly that should have raised a red flag to take a closer look at all these images and to make sure that they are really all metastases. And to our surprise, actually, a 1.5 centimeter metastasis can go undetected at pathology unless you specifically indicate it to the histopathologist to look at this area. So basically, patient did well after surgery and still our patient, but we were quite concerned, I have to say, when we read the pathological report. Thank you.